Hello everyone, this is the Shientist and I want to welcome you to another audio podcast in this series on the Ztorm focus, introducing the Shientist. This will be an overview on evidence and science excellence throughout healthcare. And this is another Ztorm Lobostics production. And as the previous audios and podcasts were broken down into three segments, this will be will have a similar format. I'm going to provide some background around this subject entity, and then the crux about this focus, and then a brief summary, bringing this topic together in a as a bringing the subject entity together with the context overall. And as with previous audios and podcasts, I am also going to highlight some references on and citations that listeners can follow up with at their own time, in their own time. And so to begin with, I want to provide a background around this, and what does it mean when we look at and explore and want to explore evidence and science excellence throughout healthcare. What does that really entail, and what does it really look to bridge in relating or regarding those areas in healthcare which could be more integrative. And apologies in advance if this podcast or audio may sound similar or similar to a previous or one of the initial podcasts or audios that have been done in this series, but this will be a kind of more in-depth audio looking at science in areas of healthcare in line with long-term condition groups, and again there will be a little bit more focus on kidney care practice, and more around areas of delivering an understanding of areas where there have been traditionally issues or gaps in and around commissioning commissioning for areas in long-term condition groups, and also some focuses on how there can be more integrative practice or integrated practice, leading to more holistic ways of linking and bridging practices, and how that can ultimately encompass a more robust reform in areas where there has been or have been issues for quite some time. So to begin with, a bit of background around this. The National Health Service, or the NHS, the long-term program or document that highlights the long-term plan, around the NHS, which was published a document or an understanding that was published in 2019, confirms that or highlights really that that there would be a shift towards integrated care and place-based systems, and gives to help give or prompt a strong or robust boost to areas that are areas of healthcare that really really and truly belong to long-term condition groups, and that is to also and the long-term plan or the NHS long-term plan that was published in 2019 looks to integrate that focus with or where long-term condition groups are focused. There would be a link with a public health model, and together really there or ultimately there would be this expectation where the main mechanism for achieving best practice, if not excellence in practice, where healthcare is concerned, that's what ultimately the way the healthcare around these around long-term condition groups, a joining of across several entities would actually stand to benefit patient care more in its entirety. And that's also been highlighted in a publication by the King's Fund in 2018. So indeed, so it's important to highlight that indeed the NHS long-term plan also requires every NHS NHS organisation or a National Health Service organisation, and local partners really to become part of more part of integrated or integrative care by April. The expectation was by April 2021, and in that context, the NHS long-term plan 2019 also expected or highlighted that that through integrative care practice and integrative care models of working even, that would be part and parcel of patient care, and it would be a pragmatic and practical way of delivering aspects of healthcare between healthcare sectors. In primary care and in secondary care, or as part of specialisms, and across physical and mental health services, and also health and social care. Or so when we talk about in the UK or in England, when we talk about integrative care, there will be a podcast later, an audio later in this series, focusing on electronic patient records, or EPRs. So when we do talk about integrative care, and a link between healthcare sectors in the UK or in England, at least, then we are looking at different areas of healthcare to be more aligned, so that patients can really benefit across different focuses, and have their requirements met by having a link with the appropriate health professional who might have expertise around different areas of health. So, for example, a typical example around this, at least, would be to highlight that, for example, if someone has, for example, needs a kidney care service, or a nephrology service, and knows and the patient has something wrong, let's say for with their kidneys, for example, typically, then the expectation would be that that patient the individual or the patient can be seen by a professional in that arena, in that remit, i.e. by a professional who knows about kidney care, but also have access to health professionals who would be able to provide understanding around kidney care, where a question might be more specific, that, for example, not one that a clinician or a kidney care physician or clinician can answer off the bat, so to speak, but where, for example, the question might be more relevant to an area of healthcare where, for example, a different health professional would be better or smarter to help answer that question. Obviously, on first premise, it would be that integrated care would be such that a patient or an individual be able to access a health professional in between sectors, pretty much at their own convenience, but have access to other health professionals if a clinician or a nephrologist in this case, where a kidney care practice is concerned, may not be able to answer. So if it's around tests and investigations, they would have an understanding around the test and investigations as well, but for more specific areas around that, for example, there may be other allied health professionals that might be more suited to actually help answer, and these health professionals may be best to answer these particular questions, given their skill base and their training and their understanding around the different aspects of, for example, diagnostics. So integrated care would see access to different professionals at different time points, and where really it would be educational perspectives to support the patient at different time points, and that could be understanding the context that comes out from that would be part and parcel of the patient's electronic patient record, or EPR. Now, that is in a broad sense what integrative or integrated care should be about. In that way, also, just to surmise, really, that if it's something to do with kidneys, then a patient is not going to be signposted, or should not be signposted, to someone who is a cardiologist or a someone who has practiced, a health professional that practices around cardiology, or if it's something to do with for example, to do with osteoarthritis, for example, then there's every reason that a patient could be referred to a physiotherapist, or might want to see a physiotherapist, but should probably see an orthopedic health professional. So it's knowing patients and where integrative care is concerned, it's knowing as when and how really to access health professionals, but also knowing how to navigate aspects of healthcare so that that also stands them in good stead, really, to link their areas of healthcare. It is also important to note that with what has been documented or highlighted in the NHS long-term plan in 2019, it also expects that streamlined and integrative care typically should involve areas of commissioning to make shared decision making or informed decision making on areas of the around, for example, long-term condition groups, and in and around areas of, for example, population health, and again, where the NHS long-term plan is focused. It looks to focus on a public health model. It's also important to highlight that that sort of implementation will could be a way to help patients who probably struggle the most, and then reform in regard to that. Therefore, reform would be where the payment system would move funding away from activity-based payments, and ensure really that most of the funding of where integration could be more could be a positive for all, would be that that would look to ensure that funding is actually more population based, and there is more around this in the King's Fund report that was published in 2018, and there are other documents, including, of course, the NHS long-term plan, which was published in 2019. So delivering the NHS long-term plan and meeting increasing demand may put health and this is something that is a little bit debatable, that delivering different focuses around the NHS long-term plan in 2019 may put pressure on different sorts of allied health professionals, and some allied health professionals may have the skill base and the training and even the knowledge base to provide patients with long-term conditions areas of healthcare, but they may not be appropriately uh, appropriately tasked tasked to support patients on the front line, and so and that would mean that uh, patients or individuals would automatically um, uh, uh, go back to their family physician or primary care um, primary care teams um, um, uh, as a first route of getting uh, a particular ailment addressed. And there is obvious obvious issues in current healthcare in aspects of the NHS, although it's done wonderful things for a great many people for over 70 years, or 70 years since its conception. The problem is that the mindset of health professionals on the front line has not um, uh, adapted um, to really include um, uh, allied health professionals or their allied health professional colleagues um, uh, more more robustly, and then that is then um, can be and has been problematic. Um, uh, Now, in this context, whilst delivering aspects of implementation of healthcare that's been documented and highlighted in the NHS long-term plan in 2019, and where where the report says there may be challenges because of the people will be living longer in some in which is fantastic in one regard, at least, but that might pose increasing demand or increasing pressure, sorry, on allied health professionals, and so it will be crucial to address areas of recruitment and retention issues to ensure that there is an adequate supply of skilled staff in future, and this is across different areas of healthcare, uh, not and in between healthcare sectors, not just frontline staff or healthcare professionals. So this actually then comes on to the point where it requires action at both national and local levels. It also means that that because, for example, if patients are living, individuals and patients are living longer, in one way, it can also be said that those delivering healthcare, whether on the front line or in between sectors, or those who are allied health professionals and part of frontline care, but not really so involved in patient care, they also may it is it should be no surprise to hear in some way that they will actually there is a more likelihood that they will stay in their roles or in their posts for longer as well, if, for example, let's say individuals or patients prefer to see that health professional versus someone else. Someone, for example, new in post, let's say. That should be no surprise, but it's also important to know that in this context, those who have been in posts, for example, again and again, I will give the example where in between healthcare sectors, but also between different allied health professional groups, and so not just frontline staff or healthcare professionals, but where those who have been in certain posts or position for some time, that they have other roles or other aspects of their, for example, their training that haven't been implemented for, let's say, for some time, that those aspects of their training can develop into whilst there would be development around that throughout aspects of their throughout their career, let's say, or their work and in their employment, that those roles or that effort should actually be part of their work if, for example, they are not for example, wanting to leave their roles or their posts, but happy to focus on aspects of their posts that would allow them to continue their professionalism, but towards the more latter parts of their career. So, for example, if by and large, health professionals, irrespective of what background they've trained in and what they've trained in, every one of them would have had a focus, a specific focus around aspects of educational support or education, and that educational understanding should and could be part of their their focus, more specifically at the latter years of their work, of their posts and what they are, if they are not able to or want to leave the post entirely. This then means that they still continue, they continue developing, but the focus becomes more around the educational aspects, more so than, let's say, for example, the treatment and the diagnosing and the I would say the forefront areas of practice that they may be used to or once trained in, but now providing more educational aspects. And one could also debate quite easily that, well, shouldn't that be what health professionals should be doing as part of their post throughout? And the answer is, well, yes, that's what they should be doing, but there are time constraints. There always have been. And so for those who would be on the front line, at least they could be focusing to integrate aspects of the educational support to make sure that patients or individuals are receiving that, where that in retrospectively has been not as strongly focused as it should be or it should have been. So that's important to take some understanding of. So that also then drives the focus around involvement, where both individuals or patients and professionals are more involved in aspects of healthcare where traditionally it's been health professionals providing providing health care that's been required or needed, and the patient being a recipient of that, and that's all the patient has done or the individual has done. Whereas involvement should imply more imperatively that actually healthcare should be bi-directional, or should be directional from both sides, and that actually both benefit, and there are obvious advantages of that. So that means that when there are those kinds of what might not seem as a role for health professionals or allied health professionals who are perhaps not patient facing, this actually does become a patient facing, and then that then prompts involvement in more direct patient care through actually novel models of working, novel models of collaborating and working to ultimately see that there is evidence and science throughout healthcare. Also, in line with this, since the late 1990s, commissioners, or those who were prompting or propagating aspects of healthcare funding in areas across the National Health Service, or the NHS, they've worked really to implement guidance from the Department of Health, which prompted a specific cycle of commissioning, and that cycle of commissioning I won't delve into too much, but a further understanding around that can be identified in a paper by Smith and their team that was published in 2019 as well. It was in April 2013, however, that primary care trusts were to be replaced by new statutory GP-led clinical commissioning groups, or CCGs, and those would take on similar responsibilities to commissioning, and they would be responsible really for highlighting which areas of healthcare services would require areas of funding or be subsidized appropriately. And then clinical commissioning groups have been charged or tasked with funding, planning, and procuring health services to meet the needs of local population, and that has been in place retrospectively for some time now. An NHS commissioning board then oversees and supports that so that areas of healthcare, and even some areas and specialisms across secondary care are also commissioned appropriately. That's been highlighted in a paper by Shaw and his team and that team in 2013. So I want to now go into the crux, having given just an overview as part of the introduction. So at present in the NHS, or the National Health Service, the majority of allied health professionals are employed solely against local demand. So depending on what where there are incidents and prevalences, and again I'll give the focus around perhaps long-term conditioning groups, long-term condition groups, sorry, and or other areas of healthcare that might be more might take more prominence or premise than specific long-term condition groups. There might be more demand to support and bring about allied health professionals who have that expertise to then support patients or individuals based on those areas of healthcare. And that's also been the case where, for example, on the high street, for example, we have, for example, traditionally there's been pharmacy practices that have, for example, have that have what they call essential advanced and enhanced services, and based on local demand, even the high street pharmacist can assess where they want to focus and concentrate areas of health care. And for example, if they know there is a prevalence or an increase in incidence of certain comorbidities, much like GPs or primary care physicians, they can also implement enhanced services around point of care testing or screening. For example, and I give that comparison really because that shows that there are allied health professionals who do have mixed focuses, but still we're in 2021, and those things, though there have been isolated and perhaps some exception where those examples have taken prominence, by and large and more broadly, healthcare in primary care has not changed really at all. So what I also want to say here is that at present, therefore, allied health professionals, again coming back to what I said as part of the intro here, introduction, was to say that there would be allied health professionals who might have a knowledge base, but not really using that, for example, untapped knowledge base or skill base really to help patients or individuals on the front line, because demand is not there. That could be and perhaps is, but could also be the reason why certain the reason and why certain allied health professionals are not in the main front line, and so there is the entity about the local demand. And this and the relatively small numbers of healthcare professionals, healthcare staff employed in some of the constituent disciplines can make workforce planning difficult, both locally and at national level. And that should not come as a shock or any surprise. It is important to ensure that planning for allied health professionals, however, is fully integrated into the wider workforce, um, or wider or broader healthcare, because if for example, if for example, there are practices, healthcare practices that are around but have not been implemented over, but have been, sorry, not implemented, but if they have been stagnated, then that means areas of healthcare will and cannot improve, because such health professionals who have expertise around certain areas of health, and research as well, are still not being still not being uh, encompassed as part of healthcare, more generally. And at the same time, and some of that context I've just highlighted has been published and highlighted in NHS England's document, an NHS England report in 2016. This then is where I want to highlight that for certain health professionals, it is also why it is said that there's a right time and right place for everything, but whilst that might be the case, and it does not necessarily mean that the right time and right place applies to everyone, and everyone's expectations or how they go about and approach aspects of their healthcare would not, may not, and would not align to aspects of patient, to accessing specific allied health professionals, for example, because individuals and patients are used to approaching frontline healthcare professionals, and when we mean frontline professionals, more so GPs or doctors, or clinicians in secondary care, according to particular specialisms. However, at the same time, allied health professionals, they form a heterogeneous part of the NHS workforce, and that has been published, or I highlighted in a paper by Steele and the team in 2018. So when extrapolating across different areas of healthcare, there are overall, at least in the UK, 28 separate professional groups operating within a sector, This example I want to give is more aligned to healthcare scientists, who also form part of the allied health professional groups group. And so when we talk about when there's 28, I mean that means really and truly there are 28 areas of healthcare science that that focus on different aspects of patient care, but more behind behind frontline practices, and each of them has a different set of training requirements and responsibilities, and the diversity has inherent as has the the diversity amongst the healthcare sciences in this regard has inherent strengths, but also has limitations. There are obvious limitations, of course. Patients or individuals, for example, who might have might be requested to have tests or investigations, will never actually see those particular health professionals. So that's a limitation in its own right, but it could be one could also say, or it can also be said, really, that that might be a strength as well, or an advantage. That understanding is in actually in a book publication by Pitt and Cunningham in 2009. Also want to highlight that on the one hand, this means that the NHS has access to a workforce able to accommodate different aspects of different ways of implementing areas of development and advances, healthcare advances, and these are important. It's important to take understanding of that because that means that can also help with taking on taking things on forward based on the government's, in this case the government, or around areas of health and policy, and focuses around the modernizing agenda in healthcare. On the other hand, though, of course, the diversity of the sector hampers the development of common identity and purpose. That is a very important and poignant point I want to make, because being diverse, which is what healthcare science, for example, is all about. The fact that healthcare scientists, for example, whether clinical scientists or biomedical scientists, let's say, so you have two examples there, irrespective of which one, there are testing investigations that they may receive requests following a frontline medics or clinicians request, or whoever, in between healthcare sectors, tests and investigations or requests will be based on any part of human physiology or anatomy, for example, which also brings the point in unison to at least say that the body is also diverse, but this is where where health professionals between health sectors unfortunately do not see do not have a sense of the level playing field. There is a hierarchy and has been, and of course if there's a hierarchy on that from that perspective, then of course it is no wonder why individuals or patients would always want to see a doctor and not an allied health professional, even if even if, for example, healthcare scientists were on the front line, and for example, we know that for example, pharmacists are on the front line, but individuals would go to a doctor first, and so there might be diversity, but there are barriers, and that also means that's where there is the diversity of the sector hampers the development again of a common identity and purpose. And so there is yet no single organization able to represent the needs represent the needs through useful progress, and again that's understanding that listeners can get from Pitt and Cunningham in their book publication 2009. And so and that means that the evidence and science excellence throughout healthcare also becomes weakened, because the robustness around science throughout individuals or patient care is not really taken as prominence or as it should be, because the more important aspect, obviously, and there is of course no issue to be had here, but it is why patients, if they are ill, they're not going to want to know about, if individuals or patients are ill, they're not going to want to know about the science, but then the first thing of course is to get for patients to get better and not really smarter, whereas on the other side, where it's the professional, the health professional, it's for the traditionally is for them to implement areas of best practice, is to know the science and also to implement aspects of the science throughout aspects in the healthcare that they deliver to individuals and patients. But then, because of again, whilst there might be diversity in aspects of healthcare, there also are impediments whereby the patient, the professional, in some regard, would benefit more each time, especially and more so if they're, for example, frontline healthcare professionals. And so there's that understanding to be had here. I want to also highlight some work that which was quite intriguing, and that's in a mixed methods evaluation exploring the NHS areas of funding and practice and governance. One team have highlighted to inform that further work and research is still required to assess really how that funding and practice areas of practices are impacted, or also could be more integrated, more smartly against specific healthcare pathways. And so they also say that that aligning must be constructed across multiple areas of focuses, so that service providers who would compete really to get aspects of funding, that they have a sense of clarity as well. But that means obviously there's going to be obvious disparities, even if, especially if where the local demand for specific areas of health and healthcare and long-term condition groups are potentially disadvantaged, and disadvantaged disparity also is around, would be around, and in more places generally, because if, for example, one part of the UK, for example, wins a bid to implement an area of healthcare practice for a particular long-term condition group, then obviously there would be potential disparities and even potential inequity, really, inequality and potential inequity around that particular long-term condition group in other areas of the UK. So that context can be highlighted, or if you want to read more around that study, there is the paper by Shafe and team in 2015, The challenge ahead really is to harness how skills and talents of different allied health professionals can be implemented in ways that support needs of individuals and patients. And doing that will hopefully, or should really properly place different allied health professionals at the very heart of high quality and evidence-based healthcare practices, and that's when more in unison evidence and science excellence can be um, uh, uh, seen really throughout healthcare practices and between healthcare practices, and credible partnerships and commitments really are needed between different areas of healthcare and sectors, professionals and regulatory bodies, employers, and most importantly health professionals, allied health professionals themselves, so that in order in one way or another that would make the overall vision of the NHS and what was and the mission around the NHS that was a focus from its conception, actually more of a reality against today's NHS. And that is context that is highlighted in the long-term in the NHS long-term plan that was published in 2019, but also prior that there was NHS England's publication in 2016. So now to just bring this to a close and just give an overall summary, considering the healthcare science behind certain long-term condition groups such as chronic kidney disease, its diagnosis, disease trends, and progression in and between healthcare sectors, commissioning groups or areas where funding is concerned, perhaps should actually reevaluate service provision to support patient care, given an aging population, but also a look at how the advantages and disadvantages of the traditional ways that healthcare is provided, in, for example, routine, for example, where individuals and patients might have routine outpatient appointments, for example, how those can be delivered in a smarter way, and also where provision in view of the changing patient needs or individual needs, and the workforce challenges, and the advances, there should be an understanding of how certain reforms are more inclusive. That's a context that has been highlighted by Howell 2010 and Shaw and that team in 2013. Initially, and perhaps more ultimately, it is important to highlight that highlight gaps wherein integration really can be improved, or how they can be improved, and educational aspects and bringing that back into mainstream healthcare practices is actually perhaps should be viewed as a win-win situation, because patients or individuals will feel more included, and also where they have when they have not just access, but also have understanding of their healthcare through context of areas in language and literacy, for example, then that actually is not just about inclusion, but also about integration and robustness. They get an understanding of the evidences that the very health professionals that are looking out for them, providing them healthcare, that they actually get an understanding of the science and evidence base, and then that actually brings the evidence and science excellence again throughout healthcare. They say there is a responsibility on both sides, patients and professionals would stand to benefit in that regard. So now I just want to give a few references, and then I'll draw this to a close. The papers by Shaw. I will. Paper by Smith is a good starting point, or first and foremost. So the paper by Smith and colleagues and Smith and team in 2013. It's a paper publication called Skill Set or Mindset, Association between Health Literacy, Patient Activation and Health, and that's published in PLOS 1, and it's a good starting point for those who for listeners listening in. And then there's a paper by Sorry, yes, and there is a paper by Mars in 1998, um, um, though a little bit dated, but still quite an important paper publication. It's titled "A Category of the Human Mind: The Notion of the Person, the Notion of Self," and it is actually a paper in a book publication titled "The Category of the Person," and that's perhaps another place to check out, another paper to publication to check out, or look out for. There is also the papers by, as I've mentioned before, there's the NHS long-term plan, and if you look that up, put that into a search engine, hopefully that might come out as one of the top results, as part of the results that come out of the from putting in NHS long-term plan 2019 into a search engine, and the full publication will appear as part of the results. There's also the NHS England NHS 2016 paper publication that is actually also a good publication to go for and look out for. And again, doing the same things. There's the King's Fund report that was published in 2018. If you put in, for example, the King's Fund and putting long-term condition groups and the King's Fund into your search, then that should appear as part of the search, and then as part of the results when putting that in. And then there is the papers by Chef in 2015. Chef is spelled SEHEAFF. If you put that in and 2015 into the search engine, you should be able to get that. Papers that are more dated or a little bit older, for example, they tend to be accessible. There is also the publication by Steele, and that's spelled STEEL, in 2018. That is quite a good publication as well. And then there's a book publication by Pitt and Cunningham, 2009. It's quite a good book, but it actually looks at healthcare from the health sciences more specifically, and it's quite a good resource. There's the publication by Howell as well, and Shaw, Howell 2010, and Shaw and that team in 2013. Again, should be accessible whilst after putting those into your search engine. Howell, spelled HOWWELL, and that's 2010, and Shaw, SHAW, um, in 2013, and though when I looking at those what comes out on the search engine, normally based on what's been discussed and highlighted in this audio, hopefully it will become obvious what paper publication I would be I've been referring to or highlighting, and of course there may well be other publications if you do not get find that you get access to the ones that I'm referring to here. Thank you very much for listening, and I look forward to highlighting some more context in another episode on the Ztorm focus. Thank you for listening to again. This has been a Ztorm Lipostics production, and this was again a topic on evidence and science excellence through healthcare. Thank you.